It was a calm Tuesday night in the ER when we had a walk-in around 11:45 p.m. A middle-aged woman in her late 40s arrived, clutching her left arm, clearly in pain with swelling at the distal radius. There was no deformity, but her description of a fall down a short flight of stairs suggested a possible fracture. I assisted her onto bed 7 and conducted a quick neurological check. Her capillary refill was normal, and there was no numbness or tingling in her fingers, only the evident pain and swelling. I went to retrieve her chart and order a portable X-ray, taking only about 90 seconds. I distinctly remember the time since I was also checking on another patient. When I returned to the room, I noticed a man standing next to the patient's bed. He appeared to be in street clothes, not scrubs or a visitor badge, and was simply observing her from a couple of feet away. His posture was stiff, almost frozen in thought. Initially, I assumed he must be a relative who slipped in while security was distracted. I quickened my pace to ask who he was, but by the time I reached the curtain, he was gone, without a sound or movement. The patient, still sitting upright, was fixated on the TV. I looked around to see if anyone was still around, but there was no one behind the curtain or in the hallway. Unsure of what had just happened, I asked the patient if someone had come in to check on her. She looked puzzled and said no, she had been alone. I pressed further, describing the man, but she shook her head, insisting no one had entered besides me. I then took her vitals. BP 13886, pulse 92, oxygen saturation 97% on room air, documenting her pain level as a 6 out of 10. About 15 minutes later, the portable X-ray technician arrived, and as we stepped out of the way, I scanned the hallway one more time, still expecting to see someone who shouldn't be there, but there was nothing. After things settled later that night, I reviewed the security footage from a camera over the nursing station that partially captured room 7. I saw myself leave her bed, but there was no sign of anyone else entering or leaving. I decided not to mention what I had seen to the patient, wanting to avoid causing her unnecessary fear, yet I couldn't shake the image of that man from my mind. He had been completely motionless, his body angled just enough that I never could see his whole face. This wasn't the first odd occurrence in that room. Anyone who has worked in our ER long enough knows Bed 7 has a strange history. A few years back, we lost a middle-aged male patient there due to a heart attack. His wife remained by his side until we called the time of death, standing right where I had seen the man. Maybe it's all just coincidence, or perhaps I was simply fatigued. In this line of work, you learn to avoid jumping to conclusions. We deal with enough real trauma without getting distracted by unexplained phenomena. But I trust my instincts, and that night I know what I saw. We treated the woman's arm, confirmed it was a clean break, and sent her home with a temporary cast and a follow-up appointment. As I escorted her out, she briefly glanced down the hallway toward room 7 and asked casually if the place was old. I told her it was built in the 70s, and when she said she thought she saw something move earlier, she shrugged it off as maybe the effect of pain medication. I smiled and let it go, knowing there's no protocol for dealing with the unexpected sight of someone by a patient who isn't really there. You can't document it or call it in. You just take a breath, stay calm, and do what you've been trained to do. In the ER, sometimes not everything that enters the room leaves again. Some just linger. There's one room in our ER that most staff tend to avoid discussing. It's not for dramatic reasons, but because it defies explanation, which is unsettling in a place defined by facts and procedures. It's designated as Storage 3B, concealed behind utility closets in a back hallway near the trauma area. If you're not paying attention, you might overlook it entirely. It has no signs aside from a faded label on a rusted door. Most new staff don't even notice it until someone mentions, "Don't try to use that one. It stays locked." And it does, or it should. No one possesses a key, not housekeeping, maintenance, or even administration. Years ago, when I was still new, I asked our charge nurse about it, but she merely shook her head. She simply shook her head and said, "That room's been locked since before I started working here. They lost the keys during renovations. There's nothing important in there." And that was the end of it. However, here's the strange part. Every few weeks, sometimes once a month or even on consecutive nights, that door would be unexpectedly found ajar. Just slightly open, not forced, but enough to catch your attention. It became a sort of unspoken routine. A nurse would go for clean linens from the supply cart in the next closet, glance to the left, and there it was, open again. Each time we'd call facilities and they would come, check the latch, shake their heads, and secure it with a heavy chain and padlock. Yet the door would open once more. One night, while I was on shift with Angela, one of our most calm and no-nonsense nurses who had been there even longer than I had, we were restocking isolation gowns in the back hallway. It was around 3 a.m., the time when things usually quiet down, and even the fluorescent lights seem weary. I remember Angela suddenly freezing, and I followed her gaze to see that storage room 3B was open again, just a narrow gap between the door frame, as if someone had slipped inside and left it ajar. We approached cautiously, not from fear but from curiosity. We didn't know if someone had broken in or if a patient had wandered in, or if something was amiss. Then we heard it. Not footsteps or voices, but something else entirely. Sounds like boxes moving, paper rustling, and a low scraping noise as if something was being dragged across concrete. Angela glanced at me and said, "You heard that too, right?" I nodded, and we stood there for about 15 seconds, listening. The sounds were sporadic, enough to convince us we weren't imagining things. Then silence fell. We called security. They swept the area, inspected the room with bolt cutters in hand, but found nothing. Just old, unused supply racks gathering dust, no footprints, no signs of life. So they locked it again and added a second lock this time. I remember one guard joking, "Maybe we should just brick it up." We laughed, but there was an undercurrent of unease. Later that week, I was back on the night shift, doing rounds, checking suction in each trauma bay, ensuring the crash carts were sealed and the O2 tanks were above 500 psi. As I passed the hallway, the door was open once again. This time, I felt a distinct change in the air near it. Not a breeze, just a pressure similar to when you open a freezer and cold air rushes out. But there was no vent, no draft, only the open door and that heavy silence as if the room itself was waiting. I didn't go in. Instead, I backed away and informed the attending on call. We went back together, but by then it was closed again. That was 5 years ago, and still, every so often, someone reports it open. It never happens during the day when facilities or administration are present, only during the nights with the nursing staff. One nurse speculated that it was once used for holding patients who passed away before the morgue was relocated. Another said there had been a fire in there decades ago, which melted the storage carts into the floor, but none of this information is documented officially. What is known is this: Storage Room 3B is no longer part of the inventory. It isn't listed on our floor maps, and even our disaster preparation plans omit it. It's simply a room we all agree to leave alone. Some nurses still check it during their rounds, while others avoid it entirely. But every time we pass by, we glance that way just to see if it's open. When it is, we report it as usual and then return to our patients, back to 4 pumps, charting, NG tubes, and Foley care, things we can explain. Yet, every time I hear an unexpected rustle down that hallway when no one should be there, I pause long enough to wonder, what happens in the room that the hospital has forgotten but something else has not? Some patients are unforgettable, not due to the trauma, the procedure, or even the result, but for another reason. Something that won't be documented in the medical records. He arrived at 8:17 p.m., which I recall because I was in the middle of recording vitals for a sepsis case when his name displayed on the board. An elderly man came in, walking, with no apparent injuries. The triage note simply stated he was dying tomorrow. That's not something to ignore, even if it seems odd. I then walked to the waiting area. He was sitting quietly, hands folded, showing no signs of discomfort. Likely in his mid-80s, he was dressed neatly in an old flannel shirt tucked in. His eyes met mine before I could even address him by name. He stood up without waiting for a prompt. "You're the one I was meant to talk to," he said. I brought him into exam room 4 and took his vitals. Blood pressure 12274, pulse 76, oxygen saturation 98% on room air. He had no fever or acute complaints. When I inquired about why he came in, he paused before responding. He said, I had a dream. I saw myself lying still at exactly 4:44 tomorrow afternoon, and I knew it wasn't just a dream. When I woke up, it settled in me. That's when I'm going to die. I've encountered my share of disoriented patients, those with sundowning, dementia, or psychosis, but he was fully coherent. His eyes were steady, his speech articulate, with no tremor or blank stare. Just certainty and calmness, not panic. He spoke of it as casually as one might discuss the weather. The attending physician that night went along with a complete workup. CBC, CMP, 12-lead ECG, troponins, urinalysis, and a chest x-ray. Everything came back normal, not even mild dehydration. We kept him under observation for a few hours. His heart rhythm was stable, sinus with no PVCs, and oxygen remained in the high 90s. There was no fever, no signs of infection, no neurological deficits. He ate a turkey sandwich and drank a cup of black coffee. At one point, I asked if he wanted us to contact his family. He replied that they wouldn't understand. He just didn't want to be alone when it happened. Still, we had no reason to admit him. He wasn't unstable mentally or physically. Around 1 a.m., after discussing it with the physician again, I gently informed him that we were going to discharge him. He didn't protest, he just nodded and smiled. "You've been very kind. I hope you'll be here tomorrow," he said. He shook my hand, holding on a bit longer than usual, and then he left. The following day, I was not scheduled to work, but when a nurse called out sick, I was asked to cover the shift and agreed without much thought. At 4:31 p.m., I was escorting a patient from room 2 to imaging. As I returned through the ER doors, our clerk signaled me to come over. EMS was en route for a cardiac arrest. An elderly male had collapsed at the bus stop downtown. He arrived at 4:43. I knew, even before they pulled the gurney out of the ambulance, that it was him. He was unresponsive and lacked a pulse. CPR was in progress. We initiated full ACLS protocol, chest compressions, bag mask ventilation, and connected him to the monitor. Flatline, no shock advised. We administered epinephrine and repeated it every 3 minutes, but there was no response. His pupils were fixed and dilated. At 4:44, I glanced at the clock. The second hand moved into place as if it were following something greater than mere time. We officially called it at 4:44. There were no indications of a myocardial infarction, no aneurysm, and no visible trauma. The labs from the night before didn't point to any hidden dangers. The coroner's report would later suggest it was likely sudden cardiac death. Unspecified, but having cared for numerous cardiac patients, I couldn't accept that. He had no history of arrhythmia, no genetic predisposition, nothing posed an imminent threat. He knew. He simply knew. After the body was taken to the morgue, I sat alone in the staff lounge for a few minutes, still wearing my gloves. I kept reflecting on the expression in his eyes from the night prior. It wasn't fear, but peace, like someone who had made peace with the end before it arrived. In the ER, we strive to combat death. We shock it, intubate it, and medicate it into submission. But this man didn't resist. He approached it quietly and gracefully, as if it was just time to go. And perhaps that is what lingers with me the most. Not the death itself, but the certainty. They referred to it as the silent code. That's how we came to label it. Anyway, I have worked in the emergency department for over 20 years, long enough to recognize when a case is shifting, when someone is slipping away. But this one remains with me. It wasn't dramatic. No storms, no strobe lights, just the subtle ticking of monitors and the familiar chaos we are accustomed to. For over 17 years, I've worked night shifts in the emergency room, and the fast-paced environment and intense pressure have become second nature. You learn to block out the sounds that don't matter. The beeping machines, the groans from patients, and even the occasional arguments in the waiting area. But some things are impossible to ignore, like the footsteps. This would typically happen after 2 a.m., once the influx of trauma cases had decreased and only a skeleton crew was left. The lights were dimmed, the hallways were quiet, and the strong smell of antiseptic filled the air. I'd often find myself restocking the crash cart or making sure the portable suction unit was ready for emergencies when I would hear them. Footsteps. Not the faint noise of shuffling or a wheeled stretcher, but clear, purposeful pacing. Our ER has a long back hallway leading past the trauma bays and into radiology, and this corridor has always given off an odd feeling, especially at night. The footsteps would start near the trauma bay, 3 doors down from the main station. They moved slowly to the corridor's end, paused, and then turned around, repeating this back and forth, just pacing. I initially thought it might be a security guard wandering during quieter hours, but whenever I checked, there was no one there. Just the echo of footsteps that had already faded. The automatic doors to that hallway remained locked, and security footage revealed nothing unusual. I recall one night when I was keeping an eye on an elderly man with a GI bleed. He was on a dopamine drip, and his blood pressure was fluctuating dangerously low. The ECG was operational, and the room was quiet except for the sound of the 4-pump. Then, the footsteps returned just outside, steady and rhythmic. I instinctively checked the hallway empty. The distinctness of the sound quickened my heartbeat. I wanted to rationalize it. Maybe it was just an echo or a nurse on the other end, but those explanations didn't hold up. Other staff heard it too, including a newer nurse named Sam, a former military medic. One night, he caught me tending to an oxygen tank and asked if I had heard the footsteps. I hesitated but eventually realized we both recognized it wasn't just in our imaginations. Some nights felt routine, as if this unseen presence had a schedule, walking from one end of the hall to the other. There was nothing frantic or erratic about it, just consistent pacing, as if waiting for something or someone. Over the years, some nurses decided to leave the night shift, citing discomfort with the footsteps among other reasons. They claimed it brought back memories of patients we couldn't save, like a young girl we lost due to a hit and run. I vividly remember the attempts we made to save her during trauma. After that, the footsteps began. We never saw anything. No shadows or spirits, just the sound and an unsettling presence. It didn't feel malevolent, merely disconcerting and constant. I've witnessed enough death and loss in this job to accept that not everything can be explained. Some entities might linger because they're not ready to depart or because they feel a connection to this place. Some patients fight for life, while others may just continue their journey. So now, when I'm restocking the crash cart or adjusting equipment at 3:15 a.m. and I hear those slow, steady footsteps echoing down the corridor, I don't react as I used to. I simply listen and allow them to pass. Hello, everyone. Thanks for watching. A special thank you to our subscribers. You keep these chilling stories alive. However, only 30% of viewers are actually subscribed. If you appreciate our content, hitting the subscribe button really helps us out. Takes just a moment, but it makes a significant impact. Don't forget to like and share to keep the eerie tales coming. Thanks once more. You make this possible. Catch you in the next one if you dare. It was a Thursday afternoon, just after the lunch rush, and the ER had settled down enough for us to catch up on some charting. Suddenly, a code blue alarm sounded from bed 12. Without a second thought, we dropped everything and rushed over. The patient was a man in his mid-60s post-myocardial infarction, already in a fragile state. He had coded earlier that very morning but was revived following a brief series of compressions and 1 dose of epinephrine. By the time I arrived, he was intubated and monitored, but his vitals were unstable. We were losing him again. I distinctly remember the crash cart colliding with the side of the bed, making that familiar thud. I took my designated position, airway management. The respiratory therapist had already connected the bag valve mask to the wall's oxygen supply, and I focused on watching for chest rise while we manually ventilated him. The monitors were flatlining, but my team moved as if by instinct. We carried out compressions, established 4-access, placed the defibrillator pads, and drew and administered epinephrine. I called out each step as if I were following a script. 1 milligram of epinephrine administered. Continue compressions. Check for a pulse. Nothing. Still no output. Dr. Simmons was at the foot of the bed, observing the monitor. He's not the type to give up easily, but I noticed the heaviness in his expression. It had been over 20 minutes. We adhered to protocol. 5 rounds, no shockable rhythm. As Stolly suggested, let's give it another 2 minutes. His voice was low but resolute. One of the newer nurses glanced at me, her eyebrows raised, silently questioning, "Is this really worthwhile?" I kept ventilating. That's our job. We persist until the clock instructs us to stop. At the 22-minute mark, Simmons issued the verbal warning. If no rhythm is seen in 2 minutes, we will call it. That's when a shift occurred. It wasn't the monitor, which continued to show a flat line. It wasn't a beep or a sudden spike in rhythm. It was his eyes. They opened slightly at first, but I recognized it. I knew what I saw. No one else noticed until I paused ventilating. Then he gasped. A deep, ragged, unmistakable breath. It wasn't agonal. It was genuine, intentional. We froze. Simmons leaned closer, assessing his pupils. "Get me vitals," he commanded. The tech was already inflating the blood pressure cuff again and reattaching the pulse oximeter. The cardiac monitor began to show faint electrical activity. Sinus bradycardia at 38 beats per minute, but it was there. He had returned. Then he whispered. I was leaned in, listening for any airway sounds when I heard him say it. Almost inaudible, his lips dry, voice raspy from the tube and the ordeal. I was already gone. That was all. I can't convey how cold the room became. Not in temperature, but in atmosphere. It was a stillness that conveyed we had all heard the same thing, and none of us knew how to process it. We stabilized him. Oxygen saturation gradually improved. Blood pressure remained weak, but we sedated and monitored him. Later, he was transferred to the ICU, intubated and unresponsive, yet alive. That whisper lingered in the air for hours. I was already gone. I documented every detail with precision. Time of last compressions, time of return of spontaneous circulation, ROSC, medications given, Glasgow Coma Scale, pre- and post-code. It has become second nature by now, yet that night I spent more time at the keyboard than usual. We don't discuss it often. It wasn't a horror show. It was simply strange, quiet, profound, and real. The patient eventually stabilized and was extubated a week later. I visited him prior to his discharge. He didn't recall much, just fragments. He mentioned a sensation of being weightless, followed by awakening to my face hovering over him. He never referred to the whisper. Perhaps he was unaware he had said it, or maybe he was. For me, that code transformed something within. Not dramatically, not like in the movies, just a quiet realization that occasionally, we find ourselves on the brink of something we don't fully grasp. That's why I continue to show up. Every shift, every code, because sometimes, even when it appears to be finished, it is not. I appreciate you all for joining me on these journeys. Your support means everything, and your reactions and personal stories in the comments are always a joy to read. If these narratives kept you intrigued or gave you chills, please hit the like button and consider subscribing for more eerie stories. Have you ever had a similar experience? Or perhaps you have your own unexplainable tale to share. I'd love to hear your thoughts in the comments below. Each of your narratives adds a new layer to our expanding community of horror enthusiasts. And if you believe someone else might appreciate a good scare, don't forget to share this video with them. Stay tuned for more spine-chilling tales. Remember, sometimes the most frightening stories are the ones that could happen to anyone. Thank you once more for watching, and I'll see you in the next video if you dare.